Hi, my name is Anthony Marin. I'm a certified specialist in reproductive endocrinology and infertility in private practice with Janaea. Today's video is about the menstrual cycle, ovulation induction, and intrauterine insemination. Before we talk about ovulation induction, we really need to cover off the basics of the menstrual cycle so that you understand how the different medications we use actually work. Essentially, the female ovaries are under control of hormonal signals that come from the brain. At the base of the brain, there's a little pea-sized and shaped gland called the pituitary, and it produces two hormones, one called follicle-stimulating hormone, whose job is to make the follicles or the eggs within the ovaries grow, and the other hormone is called luteinizing hormone, whose job is to actually sort of trigger ovulation. So at the start of a cycle, follicle-stimulating hormone levels are high. A single follicle or a single egg begins to emerge and grow. And as that follicle is emerging, the predominant hormone coming from the ovary is estrogen, and that makes the lining of the womb thicken up so that it starts to become receptive to an embryo. Estrogen also feeds back on the brain so that the brain knows when there's a mature dominant follicle sitting there, and at a certain level you get a surge of LH or surge of luteinizing hormone, and that triggers ovulation. You get the release of the egg and hopefully fertilization occurs within the tube, and after ovulation that follicle then turns into something called a corpus luteum, where the predominant hormone coming from the ovary is progesterone, and that stabilizes the lining of the womb so that it will accept and be receptive to an embryo. Most women who undergo ovulation induction have what we call polycystic ovarian syndrome. It's not the only cause of ovulatory dysfunction, but it's the major one. The current definition of polycystic ovarian syndrome requires 2 out of 3 clinical features. Firstly, it's either an irregular or absent cycle. The second thing is polycystic ovaries on ultrasound, and that just basically means that there's more than 12 follicles per ovary. And the third thing is either clinical or blood test features of excessive male hormone or androgens, and that can be things like an increase in facial or body hair, acne, and so on. It's also important that we exclude some other conditions that can mimic polycystic ovarian syndrome. Now, we don't really know what the initial cause of polycystic ovarian syndrome is, but it's probably a combination of genetics and environmental factors. But for some reason, the woman has a large number of follicles in the ovary. Each of those follicles are producing estrogen, so estrogen runs at a mild to moderately high level, and that tricks the brain into thinking that there's a follicle there, so the brain never actually goes on and produces enough follicle-stimulating hormone to actually recruit and make one of the follicles actually grow, and that then means that ovulation either occurs irregularly or doesn't occur at all. Moving on to the treatment of either irregular or absent menstrual cycles, what I want to cover is metformin, clomiphene citrate, or what's known as Clomid, letrozole, and FSH ovulation induction. Now, metformin is used for women with polycystic ovarian syndrome. It's actually a medication that's used for diabetics, and it's used for those women who have what we call insulin resistance. So their body doesn't respond to insulin like it should. And there's quite good evidence that in women with a low BMI, so less than 30, with polycystic ovarian syndrome who are not ovulating, that metformin is just as effective as the other forms of ovulation induction in terms of getting them to ovulate. There are some advantages and disadvantages to metformin. The main advantages are that once ovulation does occur, it's a natural process that's occurring. the risk of multiple pregnancy is low, and therefore cycles don't need to be monitored. The main disadvantage to metformin is that it often does cause some gastrointestinal upset, so it can make people feel quite unwell. And as well as that, it's a bit hard to know exactly when it's going to work. So some people can take metformin for 6 months and still not ovulating, and that's clearly frustrating for them. The most common medication that people are aware of is clomiphene citrate, or what we call Clomid. And essentially what it does is it actually blocks the estrogen receptors in the brain. So the brain actually thinks that estrogen levels are low. And by doing that, the brain then releases the hormone, follicle stimulating hormone, and that then leads to a recruitment and development of hopefully just one follicle and then ovulation. With clomiphene, we can normally get about 85% of women ovulating, and if you look over a 6-month period, we can achieve cumulative pregnancy rates of roughly about 60%. The biggest downside to clomiphene is the risk of multiple pregnancy, and that's because as opposed to just one follicle being recruited, 2, 3 or more follicles may be recruited. In terms of letrozole, so letrozole has been around for a long time, but has only just started to be used quite frequently in ovulation induction over the last couple of years. It works in a similar way to Clomid, but as opposed to blocking estrogen receptors, it really blocks the conversion of the male hormone testosterone to estrogens, so that actually does lead to a reduction in estrogen concentrations. But the main advantages is that the female is more likely to ovulate, she's more likely to achieve a pregnancy, she's less likely to miscarry, and most importantly, she's more likely to only sort of ovulate one egg as opposed to many, and therefore the risk of multiple pregnancies is lower. Finally, moving on to FSH ovulation induction. So we either use FSH ovulation induction in the situations where the other treatments, such as clomiphene or letrozole, haven't worked, or in situations where the causes of not ovulating stems from there being a problem at the level of the brain or the pituitary gland. And in this situation here, the female takes the FSH injections, and they're daily injections. She starts off using a low dose and gradually builds up, and we monitor the cycle very carefully with blood tests and ultrasounds just to make sure that one, and preferably no more than 2 follicles, is growing. When there's a dominant follicle sitting there, then that's when we normally advise the woman to have intercourse. And if in a situation where there's 2, 3 or more follicles, then at that stage we normally discuss cancelling the cycle due to the risk of multiple pregnancy being too high. The final component of today's talk is intrauterine insemination, and this is used either for mild male factor, where there may be a subtle reduction in concentration, or there may be a subtle issue with the quality of the sperm. It can be used in situations where the couple can't have intercourse, and that may be due to problems on either the male or female side, or sometimes it's practical reasons. For instance, the male is away for several months in the year. And finally, intrauterine insemination is obviously used for donor conception. In this situation here, we track the woman's cycle, so it's usually by a series of blood tests to work out exactly when ovulation is actually occurring. Once we've pinpointed when ovulation is occurring, we know that the egg needs to be fertilised within 12 to 24 hours, so we bring the woman in to do an intrauterine insemination, and in this situation the sperm is either provided fresh or sometimes it's thawed from a frozen sample. The scientists wash and prepare and concentrate the sperm, and essentially we load that sperm into a fine plastic catheter that's passed through the cervix into the uterus and injected. We normally get the woman to rest in a reclining chair for about 15 minutes after the procedure, and then she's free to go. Thank you for watching today's video. For more information, either visit our website, marincampbellmackey.com.au, or contact us on the displayed number for a consultation. Thank you.